Well, welcome everyone. Good evening. Thank you so much for joining us this evening. My name is Robert Latanzio. I am the Executive Director of Arch Disability Law Center, and I thank you all for joining us. We wish to begin by acknowledging the land we are all on, which has been home to Indigenous people since time immemorial. As we deliver this webinar from our homes in Toronto, to all of you across this province, we acknowledge that for thousands of years, it has been the traditional land of the Huron-Wendat, the Haudenosaunee, and the Mississaugas of the Credit River. This meeting place continues to be home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and live on this land. We give gratitude for the generations that have come before and for the creatures on the land. And we do so in the spirit of creating a safe space for us to learn and share during this evening's webinar. So welcome again, everyone. So wonderful to have you all with us this evening. I wish to also share some thanks to our partners. The partners supporting tonight's event are the Accessibility for Ontarians with Disabilities Act Alliance, Arch Disability Law Center, the Canadian Down Syndrome Society, Centre for Independent Living in Toronto, Citizens with Disabilities Ontario, Community Living Ontario, the Disability Law Intensive Program, Osgoode Hall Law School, York University, Lupus Canada, Muscular Dystrophy Canada, and the Scholl Chair in Health Law and Policy, the Faculty of Law at the University of Toronto. In particular, I wish to thank Community Living Ontario, Chris Beasley and Marcy Galipeau and their team for pulling all of this together in such a short period of time and making this webinar possible. So thank you very much. Just some quick notes before we get started. This session is being recorded. ASL interpretation is being provided. English captioning is also available. You can access captioning through a link that you received this afternoon via email and during registration as well. And the link is also in the chat as well, if you require that. So we have 1 hour for this webinar. We will have a short question and answer portion. Please send your questions through the chat. The question will be sent directly to the moderator. It won't be public. And we will try to get to all of the questions. Please keep your questions brief and concise. I should note that due to high volume, we have almost 500 registrants, I believe over 450. So it will be possibly very difficult to get to many of your questions, but we'll certainly do our best. So with all of that, I wish to tee up the topic for today. So the topic we will explore tonight is a somber and sobering one. We are in a deepening crisis with the COVID-19 third wave challenging and straining our healthcare in ways that we've never really experienced. The question for us tonight is what happens when there are not enough life-saving critical resources? How will decisions to ration or triage those resources be made? And what is the impact of those decisions on persons with disabilities who have been already disproportionately impacted in so many ways by this pandemic, and also impacted by the responses to contain the pandemic? So with that, I'd like to invite our two wonderful speakers for tonight. We are joined by Miriam Shenouda, who's a staff lawyer at Arch Disability Law Center, and David Lepofsky, who is the chair of the AODA Alliance. So we'll start with Miriam, and we have a number of questions for Miriam, and then we'll invite David to give some remarks as well. So Miriam, to begin, can you please tell us if there is currently a triage protocol in place in Ontario?
So there's a lot of misinformation and a lot of information right now surrounding this issue. And I think the best way to answer your question, Rob, is to pose and answer 3 questions. First, the question you asked, is there a triage protocol? Second, if there is a triage protocol, has it been implemented in hospitals? And third, how is it going to be implemented? The most straightforward answer to your question, and the first question, which is there a triage protocol? It's yes, there is one. Specifically, on January 13th, a triage protocol was distributed to all hospitals in Ontario. It was authored and we believe distributed by the Ontario Critical Care COVID Command Center. So it's in the hands of doctors and it's in hospitals. Has it been implemented? This is one of the harder questions to answer because we don't know. Some doctors are saying that they've been told to familiarize themselves with it, to get ready to implement it. We've heard some doctors say it has not been implemented. We do have a copy, but we're not operationalizing it. So there's confusion even within the medical community. The third question, how is it going to be implemented? We understand from the document that should Ontario hit surge, which means should there be more patients than there are ICU beds, more patients than we have nurses and doctors, then the ICU protocol, sorry, the triage protocol takes effect. The government has remained silent on this, which I think leads to a lot of the misinformation, but also points to one of the issues that ARCH, the AOD Alliance, and our partners have been pointing out for the last year, which is the lack of transparency. The government has failed to come up with a way to discuss this. And even when it's asked point blank, it's kind of sidestepped the issue, which I think, again, has lent to a lot of the misinformation out there.
Thanks, Miriam. So perhaps can you take us a little bit deeper and talk a little bit about what is so concerning about the plans that we do know or have reviewed?
So there's several things wrong with this document, but because of our time, I will focus on one or two issues. Overall, the concern is that the triage protocol uses clinical criteria that is discriminatory. It prioritizes who will get life-saving treatments and who will not. And we acknowledge that these are decisions that will have to be made should we hit surge. What we don't think is right and what the law does not support is making these decisions based on a discriminatory basis. One tool to demonstrate this is called the Clinical Frailty Scale. The Clinical Frailty Scale is 9 points, and the higher you score, the less likely you will get access to critical care. The question is, how are you scored? Well, doctors will ask questions like, do you need assistance to dress yourself? Do you need assistance to eat? Do you need assistance to go grocery shopping? Do you need assistance to use the telephone? And based on the answers that a patient gives or their family members or caregivers, then the doctors will score them higher on the scale. The higher you score, again, the less likely you'll be able to access critical care. I do want to pause here and say it is much more complex than that. I don't mean to oversimplify it, but that is on the face of it what we have seen. And we have reached out to the doctors who have authored this protocol and demonstrated how this is discriminatory. Unfortunately, they seem to either not be convinced or are still towing the party line that this is not about disability. This is just about choices that have to be made. Oftentimes, we have to look hard to find the discrimination. What is very problematic here is that we don't have to look very hard in this document to find that discrimination based on disability. I think it's also interesting that the Clinical Frailty Scale was actually created to provide better care for persons who were 65 and over. The doctor who created the Clinical Frailty Scale was worried about ageism, worried that persons who are 65 and over going to their doctor were being dismissed when complaining about certain conditions or certain things that they were worried about, and worried that doctors would say, well, you're just aging. So he was looking for an individualized assessment. So the CFS was trying to provide better care. It is now being included in this triage protocol, however, to exclude people from getting care. And using a tool that was not designed for this purpose leads us to very problematic and maybe devastating consequences. I also want to say that the Clinical Frailty Scale and tools like it are not objective. they're subjective. So when they're subjective, it means they invite certain ableist attitudes, presumptions, ideas about quality of life. And that has never been boded well for persons from the disability communities. And this is because we know that persons with disabilities measure their quality of life much higher than some doctors do. So if we're going to use a tool to decide who is going to get critical care and who is not, it is very problematic if it's subjective and if it leans towards excluding persons with disabilities. There's a lot more I can say about this, Rob, but I'm cognizant of time. So I will say that we have written a lot about this, and all of it can be found on ARCH's website.
Thank you, Miriam. And you touched on this, but in terms of what the responses have been and what the other side has been in terms of what they've been saying about these plans, is there anything more you want to add to that?
Yeah, the concerning thing is we've now been given this choice between, well, you either get no triage document or you get this triage document. And I think the consensus is that a triage document is important because we don't want doctors or healthcare workers making arbitrary decisions. Because again, that invites that subjectivity, which does not take into consideration persons with disabilities and how they consider their own value of quality of life. So to be given a choice of either no triage protocol or a discriminatory one is very problematic. And to put things in perspective, we've had 15 months, or the authors of this protocol have had 15 months now to put together a document that is not discriminatory. They've had 15 months to consult with disability communities to ensure that the tools that they're using are not discriminatory. So the defenders of this document, the authors of this document, have taken this position very strongly.
Right, and are there any alternatives or anything else that the government can do before triage is implemented, in your opinion?
So we know that there are several steps that are being taken. They're not perfect, but I think they're better than the eventuality that we're looking at, which is maybe implementing the triage protocol. One order that was released last week was transferring patients from one hospital to another. Again, if that means that a patient can get access to life-saving care, I think that's important. I do want, just for information purposes, to say that usually a patient or their family members would have to give consent to be transferred. This order in council takes that away. They don't need your consent to transfer you. Is this acceptable broadly? Not in regular circumstances, but in the circumstance that we find ourselves, I would say that it is better than having a triage protocol implemented right away. I think any steps that can be taken to not implement triage should be taken.
Right, a triage protocol that is non-discriminatory, right?
Yes,
Thanks, Miriam. And in terms of, I started out by talking about the disproportionate impact that this pandemic and that all the measures to contain it, are disproportionately impacting our communities and persons with disabilities across Ontario, but certainly impacting other marginalized and racialized communities. Can you tell us a little bit about who else is talking about this, and whether there are other communities, or is it just coming from a disability rights perspective and disability rights advocacy?
Early on, April 2020, when this was all very new to a lot of us, it was mostly disability rights organizations really ringing the bell and the alarm at this triage protocol. The first version of it came out in March 2020, and very soon after, disability organizations got together and really moved on this. But soon after, the Ontario Human Rights Commission came out and warned the government that a discriminatory triage protocol would not be sound, would be very problematic. In a lot of our submissions, we told the bioethics table and the authors of this triage protocol that they should be consulting not just with disability rights groups, but racialized groups, indigenous groups, elderly persons. And I believe that only happened once, and that was in December, very late in the game. But I think what's most interesting, or more interesting recently, is that last week, 6 bioethicists who were a part of developing this triage protocol actually came out against the most recent version. And in an article that they penned last week, they raised serious concerns about this triage protocol and pointed to advocates like ARCH, AOD Alliance, and others, and said that these are the groups that should be listened to when you're putting together such an important document, and that one that can have devastating consequences. So I think it's very, it's not something that you often see, that the very authors of the protocol that's now being distributed to hospitals are now coming back and saying, wait, no, we need to rethink this. The government needs to move on this. We need to consult. This needs to happen in public, and we need to rewrite the whole document.
Okay, thank you, Miriam, and also to let everyone know that the groups that have put together this webinar, the groups that I had listed from the outset of this webinar, released a statement yesterday in response to that article that Miriam just referred to by those members of the bioethics table. And in that statement, there are also 6 asks that we are calling on government to take action on. So thank you for that. And as we wrap up here, maybe quickly, this is the last grilling question here for you, Miriam. Lastly, what do you think are some practical strategies that a person can do to get ready if they do need to go to the hospital? And I say that with the caveat that there is still, as you said, there's still information that we don't know. There's still, things that can change. But can you give everyone maybe some strategies, a general sense of the kinds of things they could be thinking about?
So I think you're right. Based on what we know, this could change, and if it changes, we'll update any of the information that we have. But based on what we know, we think some of the very practical steps that someone can take is write a letter or record a video or find a way to put down, communicate your wishes for the kind of care you would like to receive. If you need accommodations to receive healthcare while you're in the hospital, such an interpreter or a communication support person, again, put that in a letter or record a video about the accommodation you need. You may also want to get a letter from your doctor and attach it to your own communication. You can, in anticipation, and again, like Rob, you said at the beginning, this is very sobering. It's not I don't want to have to say this, but if you think that you might be going to the hospital anytime soon, you may want to pack an emergency bag of things that you might need at the hospital and include in that bag, always have a copy of that letter or that video that expresses your care wishes, the contact information of your support person or your decision maker. And it's also good to try to keep that on your person, just in case your bag gets lost. You may want to include a photo of yourself in that letter, to make sure that everyone at the hospital knows that the letter belongs to you. All of this and a lot of the information that I've talked to you about, Rob, today is included in a fact sheet that ARCH has put together. I know we're overwhelming you with information, so if you would like to go back and read on your own and take your time with it, you can find that on our website. And again, as we receive more information, we'll update that fact sheet.
That's wonderful. Thanks so much, Miriam. That's really, really helpful. So thank you, and we will have questions in about 15 or 20 minutes. But with that, I would like to invite David to join us and share some reflections. David?
Hi there, can you hear me? I just want to make sure I'm unmuted.
Can hear you well. Yes, David.
Okay, great. Well, thank you very much. Thanks to everybody for coming and to the organizers for pulling this together on such short notice. I'm going to dive right in here, folks. the fact is that this protocol is deeply flawed, and it's deeply flawed in the view of people with disabilities, reflected through many disability organizations, through the views of the Ontario Human Rights Commission, the official public watchdog in this area, and through the views of 6 members of the government's own advisory bioethics table, which means this has got to get fixed, and it's got to get fixed now. Let me turn first to what's wrong with it. I'm going to build on Miriam's excellent presentation by just emphasizing one point. Every time she said it's discriminatory, let us be clear, it's disability discriminatory. It provides that for people who are over 65, if you have a progressive disease like MS or Parkinson's or arthritis or a number of other conditions, that your access to life-saving critical care will be affected in no small part by how you score on that critical frailty scale. And that's a scale that looks explicitly at whether you have a disability, because who else has limitations such as those it addresses? As well, if you have cancer, this protocol requires a doctor to wait whether you have a permit, like whether you're fully disabled and can't get out of bed, or lesser so. Again, that's holding your disability against you. And what it boils down to is this. In predicting it, this protocol requires a doctor to assess how likely you are to, if you need critical care, to be alive a year from now. And don't take it from me that this is a guesstimate by doctors. Take it from the head of the intensive care unit at Michael Garron Hospital in Toronto, Dr. Michael Warner, who on CBC Radio earlier this winter said that for doctors, this may involve guesstimates. And the first part of guesstimates is guess. It's dressed up to look like science by the people who wrote this. There's a lot of medical jargon, but if it boils down to potentially a guesstimate, it's not science. It gives doctors a lot of wiggle room, not because they're looking for it. They're not bad people or wrongly intended. They don't want to do this. But in the end, as a practical matter, it means that they're going to have a lot of discretion over who they say yes to and who they say no to, dressed up in what looks like medical language. And when that kind of discretion exists, the risk of disability discrimination is most acute. As well, the protocol denies people with disabilities or other patients facing critical care triage any fair process. You don't get any say. You don't have a chance to express yourself in terms of what your abilities are. And if the decision is taken against you, you got nowhere to go once 2 doctors say sorry. You're basically treated like a blob on a gurney. And we say that patients, including people with disabilities, they deserve better. So that's at its core what's wrong with it, and it's pretty serious. Now, what's the government doing, and those who are leading the implementation of this doing to get ready? Well, what they're doing worries us. First, there's a body of authorized, mandated to oversee and receive complaints about and regulate the doctors. It's called the College of Physicians and Surgeons of Ontario. If you want to complain about misconduct by a doc, that's where you file a complaint. Well, they issued an email to all their doctors within the past couple of weeks, basically saying that greenlighting that if the government tells them to engage in critical care triage, they support the use of this critical care triage protocol, which is disability discriminatory, we say. And we say that such a public regulator that's supposed to protect the public interest should not be giving a regulatory blank check in advance to doctors, especially when they have never talked to us. We've asked for a meeting. They haven't answered that request with a yes. As well, the government is considering the possibility of acceding to a request from someone within the medical profession to agree to indemnify doctors who undertake critical care triage. What does that mean? It's a fancy word for saying if they get sued for using this critical care triage protocol, they want the government to pay the bill. And we know that the insurance company, the private insurance company that insures docs, is asking the government for what they called maximum protection for doctors. I'm paraphrasing. And we say that the government should not be giving a financial blank check, nor should the official public regulator of doctors be giving a regulatory blank check to doctors in advance when this protocol is discriminatory and where both the government officials making decisions on this and the College of Physicians have never talked to us to even find out what and explore what our concerns are. What else is being done to implement this? Back in January, on the 23rd of January, a video webinar was held like this one, but it was for frontline doctors and hospitals, led by folks involved in writing this protocol and others, to train them on how to use it. And we released a report about this back on the 25th of February, and in detail, once we took a look at it, let me put it in plain language. It's an attempt to sell doctors on using it, and it is misleading. For example, it tells doctors, oh, they consulted on the development of this protocol, including with the Human Rights Commission. That sounds very encouraging, except they didn't tell the doctors that the Human Rights Commission has serious human rights concerns with the protocol. You'd think frontline doctors would want to know that. Doctors were told that there was a unanimous approval of this protocol or agreement with this, or the framework for this protocol, by the government's own bioethics table appointed to give advice on it. Well, what we found out in the past few days is that fully 6 members of that table have pretty serious concerns about this protocol. And so that sense that the notion that the doctors were being left with about it somehow being the result of a consensus, well, that's not quite the case now. And our bottom line is that doctors would use this protocol at their peril. And let me turn for a minute to what kind of defense is being mounted for this protocol. Well, the defense is pretty much not coming from the government itself. It's got others going out and doing its defense for them, particularly some of the folks that were involved in developing it. Let me give you some of the arguments. A denial that there's any discrimination based on disability at all, because they're not going to decide whether you get critical care based on your disability. They're going to do it based on your likely survival. That sounds really good, except when they look at how they evaluate your likely survival, they use the clinical frailty scale for some. For cancer, they look at disability specifically. So, well, when you use disability as part of looking at that assessment of 1 year survival, that's disability discrimination. Denying reality does not make it any different. Now, what else do they say? Well, in response to concerns like you just heard earlier from Miriam, one of the arguments made is, oh no, this protocol actually says don't hold disabilities against you if you have a permanent long-term disability like cerebral palsy or autism. Well, in other words, yes, they don't use the clinical frailty scale and whether you can do those activities of daily living, getting out of bed, eating, shopping, and so on them, but they do use it on people with conditions that are progressive conditions like multiple sclerosis or arthritis or Parkinson's or others. What does this argument boil down to? Well, we're only discriminating against some people with disabilities. We've actually said not to discriminate against other people with disabilities. That doesn't mean it's not discrimination. Imagine a workplace that says, well, we don't want to hire Jews. It's okay to hire Catholics or Protestants or Muslims, but no Jews. So we're not discriminating because we've affirmatively said that we're open to hiring members of other religions. That's kind of a bogus defense to claim of religious discrimination. It's no different here. Let me give you one last example of the kind of defenses they're raising. It's been said that, well, this may be a problem, but it's better than having no protocol. Well, that only is on the basis that if the only way to do effective critical care triage is by disability discrimination, if the folks who've drafted this can't come up with any other ideas, I think the government should find some other folks to do the drafting of it for them. Let me turn finally briefly to what can we do about it. I am always optimistic. This is an uphill battle, but folks, we've fought and won any number of uphill battles for people with disabilities. We can do it here too. We've got the wind in our sails because we've gotten some helpful media coverage recently because 6 members of the bioethics table have agreed with us. And I don't believe that all doctors agree with the views that have been argued in favor of the government by those involved in writing this. So what do I suggest? Let me suggest 3 things really quickly before, and then I'll wrap up. First, it's really more important than ever for you to convey now to your member of the legislature by phone call, by email, by Twitter, by carrier pigeon, whatever works, that you don't want this critical care triage protocol used. You don't want disability discrimination in the critical care triage protocol. Second, get to your local media. If you notice, we've gotten a lot of coverage lately, but we've been trying for months to get coverage. They need to give it more coverage, and there are news organizations who haven't covered it at all or haven't covered it enough. They need to hear from you that you want this covered. And finally, the hospitals have been told to run simulations, drills on how they would do triage if it has to happen. This is all happening behind closed doors. Why don't you contact your local hospital, ask them if they've done a drill, let us know, and let you know, and then you can make public what the results of the drills were. Let's find out how different the same case would be decided from one hospital or the next. If you want to learn more about what we're up to on this, the ARCH website has tons. Also, if you go to the AODA Alliance's website, you can sign up to get our email updates. Or we have a healthcare page. It's aodaalliance.org/healthcare. And you can see the whole track record from the AODA Alliance on this. Together we can win it, but we need your help. Back to you, Rob.
Wonderful. Thank you, David. What a wonderful way to wrap up. I think that is truly the message, that we still do have time. It feels like we've been doing this for over a year. This is crunch time. The fact that so many of you have joined tonight indicates that there is certainly well-founded concern, but also an interest to do something about it. So thank you so much, David. And certainly those 3 points that David just set out, I think are just a fantastic way to get involved. And as we wrap up the webinar, we'll build on that and offer you some tools. Again, the websites that David mentioned do have a lot of information. So please do get as much information as you can, and please do feel that you can take some action on this. So we are sort of, okay for time, but I do want to get to the questions. So we have some great questions. We'll start with one question that I'll just put out there, and David and Miriam, please feel free, whoever would like to jump in. So the first question, and what I'll try to do is pull together some themes on questions that we're noticing here through the chat. So we have a couple of questions that touch on what happens when a caregiver or a substitute decision maker is not allowed in with the patient who requires the supports or the SDM when these determinations are being made. Would anyone like to start with that?
I'm going to let Miriam lead on that one.
Okay, thank you, David. So great question. I think, this question falls under the umbrella of what we now term visitation bans or visitor policies that tend to restrict access to patients. And the visitor restriction is either to family members or caregivers or substitute decision makers. I want to be very careful here and first say that while this might happen to a lot of different people, we have to assess each case on its own. We have to make individualized assessments. So if you have experienced this, then I welcome you to call ARCH's Summary Advice and Referral Line, make an appointment, and we can discuss your case specifically. broadly speaking, you know, each visitor policy is different, whether it's at a hospital at a long-term care home or a congregate care home. I appreciate that today we're talking more about hospitals. Um, you know, because we haven't seen it happen yet, that these very difficult decisions are being made pursuant to the triage protocol, it's very hard as lawyers to say what would happen. We don't know if doctors are going to contact a family member by phone to let them know, you know, we've decided not to give your loved one access to critical care or the ICU. We don't know if in those cases they will allow you to come into the room and make that decision right there. We do know that the triage protocol right now says that this decision has to be discussed with family members. Again, I don't know how this discussion is going to take place. I don't know in what format. I don't know if it's going to be a letter or a phone call or an office meeting, which I doubt. So it's very difficult to answer this question. The only thing I can tell you is what the triage protocol says. And it says a communication has to be had between the doctor making this decision and the family member of the loved one. But again, I urge you to seek independent legal advice based on your specific case if you have encountered this.
Perfect. Thank you, Miriam. And maybe a good time to state that Arch Disability Law Center does offer free confidential summary legal advice. And you know, if you are in a situation where you feel that you need some summary legal advice, you can certainly contact Arch, and we will do our best to give you the needed advice or provide legal information or referrals or whatever may be appropriate. So thank you for that. And we have another question that takes us in a little bit of a different direction. So this is looking, you know, in terms of outwardly around whether there are any other types of triage protocols in other places that would not be discriminatory.
Well,
So there are examples of this.
it's David. Let me just say this. Our first position, and this has been raised with us before, there's some scholars who've done some work in this area, and we've told whoever will talk to us that if they want to come back to us with something else to look at, we're happy to look at it. But nevertheless, and we don't have the access that the government has to the kind of research to be able to come up with an answer to that question. But what we have said is there are things we know they can do. And these are things which even the Human Rights Commission has supported. I shouldn't say even the Human Rights Commission has supported, putting some due process and some fair process into this for patients. Instead of talking about 1 year survival, which would be that kind of guesstimating that we talked about before, substantially shortening that period, because the shorter it is, we're hopeful the less of a guess it is. The third thing that we've said is, these are among the things that are in the joint statement that we put out yesterday, we and the Arch and Arch, is to make sure that whatever they do, it's enacted in law. Because right now, this is just a memo. And it's a secret memo. If you want to find this protocol, you won't find it on the government website. You will find it on the AODA Alliance's website because it got leaked to us and we made it public. There is something inherently bizarre, if not revolting, about the fact that on such a life and death issue, you got to come to the website of volunteers like us to find this protocol, even though doctors and hospitals have all had access to it since the middle of January. Back to you, Rob.
Thank you, David. And on that note, actually, you hit on a number of questions around access to information. And we've been talking a lot about, you know, there is a lot that we don't know. We don't know, there may be other versions there, so on and so forth. But just to echo what David just mentioned, for those who have asked to get a hold of those documents, the AODA Alliance website does have those documents there. There is another question that touches on how children, the question itself revolves around children who do not communicate verbally and how parents can navigate that. But I think perhaps if you can speak to how children are impacted, or rather not impacted by this triage protocol. And if you can speak to
Let me, Miriam, do you want me to jump on this one first and you follow up if you like?
You can go ahead, David, sure.
This protocol is designed for adults, for 18 and up. We gather, at least from what we've heard, that there is or may be a protocol for those under 18, but we've never seen it. We've never been consulted on it. We don't know what it says. So, and that is appalling. There should be, it should be public, just like the adult one should be public. Back to you, Rob.
Thank you, David. Just noticing the time here, I think we will end with the question and answer period. I just really want to thank everyone for your really thoughtful questions. I wish to leave it with this message here that we will go through everyone's question. Those questions are quite important to us as we develop additional materials. So all of us that have come together on this issue, we continue to react to things as they come, and also develop materials as needed. And certainly your questions will help us understand, some of the concerning pieces that we should be addressing in those materials. So thank you in advance. With that, I perhaps, or I think it would be a really timely segue here, where I will call Marcy, because Marcy will tell us a little bit about, given everything that we have all heard and learned this evening, and David gave us some great tips on what to do, and Marcy, I think, could pull this together and give everyone some tools and links and next steps. So some action items for us all to be thinking about tonight. So Marcy, would you please join us and share some of that information?
Sure. Thanks, Robert. Can you hear me okay?
Can hear you well, yes.
Right, perfect. So Miriam had mentioned something about writing a letter. And so as a group, we actually have written a letter on, to kind of make it a lot easier for you to share that information. So if you want, you can, in order to access that letter, you can go to our website. Heather is going to add that into the chat now. And the chat, the website is bit.ly/CLO-OTP. Essentially what that tool does is all you have to do is enter your information, your contact information, and essentially a letter will automatically be sent to Doug Ford and Christine Elliott simultaneously, signed by you, assuming you agree with the content in the letter. We've also set up some content on our social media feed, and Heather will also share that in the chat. There we go. And that is a bit longer, so I'll leave it there in the chat so you can access it. Some of that information is really key, and we wanted to make it easier for you to access, like there are key messaging. And I'm just going to add the spotlight here. And the last thing I'll mention is that we will be sending a follow-up email to everyone who has registered for this email or for this webinar. And it will include basically every resource we mentioned tonight. So the fact sheet, a link to the tool, the letter tool, the Twitter carousel, and a couple of additional, I think we'll link to the AODA website as well to make sure that that information is easily accessible. And of course, it is being recorded, the session's being recorded, and so you will also have access to a recording of this. So that's it. I think that's pretty much all I had to say. So thanks very much.